Here. Did you
Okay.
hear me?
I
Yes.
couldn't hear you the first time. Can you hear you now?
Okay, thanks.
Dr. Chapa? Dr. DePhillips?
Here.
Dr. Farmer?
Here.
Dr. Goodman?
Present.
Dr. Ibrahim?
Here.
Trina Ida?
Present.
Lee Johnson?
Here.
Dr. Keller?
Here.
Dr. Lakey?
I am here.
Dr. Martin?
Here.
Dr. Martinez?
Present.
Dr. Maxwell? Elizabeth Mayer? Dr.
She is here.
is here? As she said.
Yeah, I see her. Dr. Mayer, can you say here? Okay, go ahead.
Okay. Elizabeth Mayer? Dr. McCollum Smith?
Here.
Dr. Mitchell? Dr. Nemiroff? Dr. Newport? Brittany Nichols?
Here.
Dr. Oliphant? Dr. Olvera?
Here.
Dr. Pliska?
Here.
Dr. Raji?
Present. Here.
Olga Rodriguez?
Here.
Scott Schleichlin? Sue Shell?
Here, thank you.
Progress.
John Scott?
Here.
Dr. Suarez? Luann Southern?
Here.
Dr. Thompson?
Here.
Dr. Wagner?
Here.
Dr. Wakefield? Dr. Watson? Dr. Williams?
Present.
All right, so we have 24 people. We have quorum. So we can go ahead and get started. A couple of ground rules, especially for new folks here. Please turn your cameras on. I need to make sure that we have quorum. If you're going to leave, please let me know. Again, need to make sure we check our numbers, make sure we had enough people. And again, would advise people not to use the chat function. If you do, you unfortunately have to hear me read your comments out loud in order to be compliant with the Open Meetings Act. And so we would advise you just to raise your hand and make your comment. With that, we have a couple of new people here today with us. From UTMB, Dr. DePhillips, welcome to the Texas Child Mental Health Care Consortium. Dr. Wagner, I don't know if you want to introduce her or have Melissa introduce herself.
Well, I guess I'll say a few words. Dr. DePhillips is the director of the Child and Adolescent Division of Psychiatry, and she's been very involved with the consortium projects, especially with regard to CPAN. So she's really familiar with the workings of this group, and she does an excellent job in everything.
All right, very good. And then from our team, Rachel, you want to introduce new team member?
I want to introduce Ashley Steenberger. She's a new project manager on our team. She'll be working primarily on our CPAN and PeriPAM programs.
All right, very good. And then Nisa Adams, welcome. We'll be helping in the communications area, and good to have you here. Are there any other introductions we need to make before we begin? Okay. Dr. Amador, is your hand up or did you want to introduce yourself?
Oh, I just wanted to put my hand up to mark that I was present.
Okay, very good. Are there
Welcome to everyone.
any other executive committee members that didn't get to introduce yourself or let us know that you were present when we did the roll call?
Hi, Elizabeth Mayer. I'm here. Thank you.
Good to see you, Elizabeth. Thanks for
Yeah,
being.
nice to see y'all.
Anybody else? Seeing none, let's go ahead and jump into the rest of the agenda. I think we have a full day. I think we'll be able to finish on time. We're going to have to make sure that we're done by about 1 o'clock because of another group that wants to use this room. And so I'll be pushing just a little bit to make sure we move forward. But again, it's great to have everyone here. With that, we need approval of the minutes. If everyone would take a quick look at the minutes. If there's any questions, let us know. Otherwise, I would take a motion to approve the minutes. In a second.
Move approval.
Dr. Wagner moved approval.
Second.
Second from Dr. Babatope. Any other further conversation, comments? Hearing none, all in favor of approving the minutes, signify by saying aye.
Aye.
Opposed?
Aye.
If you disapprove, say nay. All right, let the record show that there was a unanimous approval. With that, Nagla, let me go to you for the update for the new and emerging child mental health researcher awards.
Thank you. So just wanted to give you an update on the upcoming grant that we're going to be releasing on the new and emerging child mental health researchers. And the slide was going to come up in a second. Let me just describe what and remind you what this grant is about. So its focus is on the Texas child mental health area, and with a focus on supporting the training and research for new and emerging researchers. Researchers must be related to improving the children's perinatal mental health systems and or children perinatal mental health services in Texas. Also included is the gaining of an understanding of the diagnosis and the causes of the childhood psychiatric disorders. So one of the things as a reminder is that basic research and pharmaceutical clinical trials are not eligible for this grant. And that once the promising and evidence-based practices are identified, that we'd like to see ways that we can incorporate it into services that we provide and that other state agencies provide as well. Just like before, there are 3 types of grants that are offered under this grant type, and those are research and career development. There's a postdoc, fellow and trainee, and then there is a research project. And that we're really encouraging for those who may not have had a recent or have had been a PI on an R01 NIH grant. We would like, sorry, there's a bit of feedback here. Somebody has their computer sound on. Next slide, please, Rachel. So we are looking at the eligibility for this grant is focused on those who are part of the consortium. The HRI is affiliated with a consortium, and they can partner with some Texas-based investigators that are not associated with the consortium. We're prioritizing those applicants, as I said, who are not, who had not had an NIH R01 grant in the past, and that trainees, including clinical and research fellows, are eligible and encouraged to be part of this. Then finally, proposals that include more than one consortium institution are really encouraged and will also be prioritized. Next slide. So if you remember last year when we did this opportunity, we tried to identify some research priorities and we focused it on the Health and Human Service Commission's priorities that include some of their programs that they wanted to evaluate. This year, we've reached out to a number of state agencies and organizations, and that includes HHSC, the Department of State Health Services, Family Protective Services, Juvenile Justice Department, and the Texas Council of Community Centers. We also reached out to Hawk Foundation, and we reached out to the medical directors for the Texas Consortium programs and our evaluation groups to get some ideas about questions or focuses or programs that need evaluation. And so we will be providing those in the notice of funding opportunities so that if researchers are interested in following up of those questions, they can go ahead and do so. We'll also provide contacts from these organizations and agencies so that they can follow up on those questions that we'll be providing. Next. The other thing that came up from last time is that there were times where some institutions may not have had the mentorship for that applicant that they needed, just because, you know, of faculty not being available or not having the time to provide that. And so what we're establishing this time around is a list of mentors that could help, and they would help any of the institutions. And so we will provide their names. We had 10 that had volunteered. And part of what they're going to do is provide mentorship with the proposals, provide mentorship with the actual research and grant, and they can be up to 5% support, salary support on these proposals as well. Next. This is kind of a draft timeline that we've established, and we'll be communicating some of this information kind of going forward. So we're going to be providing an informational session coming up in February, hoping to release the NOFO on March the 3rd. And we're going to go through the same process as we've gone before, which is a pre-application process where each institution would be asked to have the applicants submit to the chair, and then the chair would review their application and make sure that these are the applicants that they would like to represent their institutions. Once we go through that process, we would notify the applicants that they can go ahead and submit a full application and then go through the process. We will also have some external reviewers, just like we had in the past. And this grant would start in September 1 of 2025. So FY26 and FY27. That's all I had. Are there any questions?
Let me jump in real quick,
Sure.
and then Sarah, I'll go to you. Again, I want to thank everyone that's been part of this. I think this is an exciting initiative from the consortium where we've been able, this last round, we invested $8.4 million into young investigators across the state of Texas, basically across all of your systems, all the systems and the institutions that submitted an application. We were able to find somebody to be able to fund. And that does several things. It builds the bench strength for research in our institutions, but it also, because of the way we targeted it, working with HHSC, there are real problems for the state of Texas and trying to figure out how do we bring in academic excellence across the state. The academic excellence across the state to solve these initiatives. So we're going to be a little bit broader this time, not only go to HHSC, but also DFPS, the other entities that were listed earlier today, because they all are challenged with these programs. We have kind of legacy programs the state has used, but there hasn't been the evaluation of them, of whether they're really effective or not. And this is a way that we can really figure that out, and then be able to figure out if other programs need to be broadened or not, depending on how effective they are. So the amount of money that we will be able to put into this, I can't tell you yet because the legislative session is just starting. We'll talk about the budget a little bit later. I don't know if we'll have that $8.4 million, but it looks to me like there is dollars. There are dollars there right now, so we'll be able to do part of this. But if we want to be able to award these come September, we need to start now versus waiting till the end of the session and then starting the whole process. And so let me stop there to see if there's questions. And Sarah, your hand was up a little bit ago.
I was just wondering if the researchers that received a grant the first time, if they wanted to continue their same project longer, is that going to be a possibility?
I think they can go ahead and apply. Yeah.
Okay, great.
And then there'll be a decision made as we try
Okay.
to.
They'll be
Well,
considered
yeah,
at least though.
yeah,
Okay,
yeah.
great.
Octavio?
David, to your point about effectiveness, are there going to be, or do we need evaluation dollars or component for that to look at the program overall to be able to tell the legislators, hey, this is having an impact?
I don't think in this part of the budget that we'll be able to pull off evaluation of this. I think that we can talk about the overall evaluation of the program and what's going on, and we can collect data related to that. And so I think that's part of the administrative role that we can do, is to look at the number of people funded. Do they stay in the state of Texas? How is the information received by the state agencies related to the evaluation of their programs? But we'll have to figure out if there's need for further evaluation beyond the administrative role. Nagla, did you want to say something?
Thank you, buddy. Just that we've received the first batch of reports, the first quarter report, and it looks like all the researchers pretty much have advanced their research in a lot of different ways, meaning they've already set up their surveys, they've already collected some data or set up their databases. So they're really moving forward. And given that some of the contracts took a little bit extra time before they were executed, the fact that they've moved that far, they're really doing a great job, most of them. Yeah.
So there is that reporting that takes place. We don't just give the money out and say, go and do good. But there is a quarterly reporting that takes place to make sure that they're moving forward on the projects. Okay. Any other questions? I don't, Dr. Raji?
Yeah, just quick question about the eligibility for the applicants. So the associate professor or below, does it apply to the research project also, or just the career development stream?
Nagla?
It's for the career development. So you can have higher than associate professor or assistant professor for the research project. Again, we are hoping to have people who have not gained an R01 NIH grant. However, that is not a restriction completely. So it depends on the research, it depends on the partners, and it depends on a lot of other pieces. And again, we have external evaluators from outside of Texas who are going to look at the rigor of the research and what can be gained out of it, as well as usually we will have also some of our reviewers be Texas-based reviewers that know the programs and understand the Texas priorities.
We want to invest in young investigators so they can become established researchers, but I think all of us know that there are people that are very good clinicians that may be more advanced in their career, but now want to add a research component, and that is eligible, and we would support that.
Thank you.
Thank you. Any other questions? All right, I don't see any other hands. Again, more will come, more information will come, but you know, as we figure out how much funding will be available for this, but we are looking forward to be able to, again, fund individuals, make those announcements in the summer, and have people start in September. With that, let me turn the podium over to Rachel Jew for an update on TChat and a couple of policies that we're working on. Rachel?
Thanks, Dr. Lakey. Good morning, everyone. So here is our TChat expansion report as of November 30th. You'll see that we are now active in just under 74% of all campuses, and that represents 78% of the student population. We have made really great progress over the last few years, and just a few campuses now are in a planned status. That's 3% that we have left. And we hope to see some movement in those last few campuses over the next few months. Here's just a proportionate view of the visualization from the slide before. We have 5 HRIs with campuses that have an onboarding date, and you can see that most of them will occur in September. Four ESCs this month had increases in active campuses. Here you can see our upward trajectory, as I mentioned, just continued growth. And the primary reason for campuses and districts that decline continues to be that they have existing mental health providers. Any questions on the report? Okay, I'll move on to give a quick update on the TChat LMHA pilot, just a quick verbal update. As a reminder, and for those of you who don't know, the pilot does aim to increase access to long-term care for our TChat students who need it. We have been meeting, a work group has been meeting regularly, at least a couple times a month. And we are planning to host a meeting to all interested HRIs and LMHAs participate. That meeting will be February 3rd at noon, and emails should have gone out making that announcement last week. If anybody would like a link directly, just let me know and I can send that to you. In that meeting, we'll review participation requirements, just share a little bit more detail about the pilot. And then from there, we'll open it up to, we'll start receiving applications and then select 3 to 4 HRI and LMHA partners to participate in the 6-month pilot. And then we'll have an evaluation period after that. So we'll continue to keep you all updated on our progress there. Dr. Pliska, do you want to add anything?
No, that's a good review. Nothing to add.
Okay. Any questions on the pilot? Okay. And my last TChat update, you all should have received a revised version of our referral and enrollment policy. This is a policy that you all approved a number of months ago, and we made just a couple of clarifying edits after receiving some questions about a particular subset, of students. In particular, those who are in alternative education programs and those who are involved in the justice system or receiving juvenile probation services. Thanks, Meadows, for providing some feedback. So we did, since you all received this edited version, I did make a few changes just to include those youth receiving juvenile probation services. So again, this is just a clarifying edit. We didn't increase or change, the scope or add any requirements. We just wanted to make it clear that, for this subset of students, if they meet the criteria that we've already set in the policy, then we will accept those referrals. Any questions about the policy change?
So Rachel, do we need to have approval by this executive committee?
So given that there's not a scope change, I don't think that that we need to put this to a vote. But we'll leave that to the executive committee if you all feel like, for this and future, clarifying changes to policy, if you feel like, you need to make a vote, then
Okay.
we can do that.
Yeah, we don't have voting on it. So
Oh, you're right.
on the
Not
agenda,
today.
so we won't make any votes. May take appropriate action. My lawyer says that we can make appropriate action. So I guess since my lawyer says that we can make appropriate action, and just to make sure that everyone feels comfortable that we did this in a transparent way, I will take a motion related to the approval of the additional language.
Are we, in some sense, we're amending the policy,
Yeah.
right?
Yeah.
So it'd be like an amendment to a
Yeah.
bill or something. So in which case I move that we add the suggested language to the referral and enrollment policy.
All right, I have a motion by Steve Pliska.
Second.
Second, Dr. Farmer, okay. Any further discussion? See none, all in favor signify by saying A.
Hey.
Okay.
Sorry. Opposed, nay. All right, anybody abstain? So let the record show that we got unanimous approval. What's this? Okay. So there's several people that have joined since we started. If you would identify yourself, that would be great.
Jeff Newport.
And let the record show Dr. Newport is here. Anybody else?
Sarah Wakefield.
Dr. Wakefield? Okay, very good. Anybody else?
Keisha Oliphant.
Welcome, Dr. Oliphant. Anybody else? All right, very good. Well, let's move on then to executive committee item number 5, the performance management plan update. Rachel?
So again, just a quick verbal update here. The last time we met, you all approved the implementation of a performance management framework for the consortium. And we are starting with TCHAT, CPAN, and PeriPan. The external evaluation team has reviewed some existing logic models that both internal and external evaluation had developed when the consortium was first convened, so those revisions to logic models for those programs will be discussed in a meeting later. We expect to share that with you all next time we meet. Our internal evaluation team is proposing some quality improvement metrics to get us started that should tie closely with those logic models and the goals and outcomes that are outlined in those logic models. We will be seeking HRI input, and of course keeping you all updated as we progress with that project. Any questions?
Any questions from anyone? All right, very good. Thanks, Rachel. Dr. Wakefield, let's go to you related to the update on PeriPan.
Hi, thank you. Yes, we'll get started. So we continue to see some increase in enrollment. Our enrollment stats are right here, over 1,000 obstetricians in Texas, and which is a really big deal, I think, and something that we should acknowledge, that's a lot of very, very busy clinicians that our teams have reached and that they have enrolled in this program. 253 obstetric clinics, and then 58 women's or maternal health clinics and 20 midwifery practices. And just as a reminder, those 1,000 OB-GYNs are not the only people who were enrolled in PeriPan. We are following that metric because our pediatricians and family medicine docs, many of whom enrolled originally in CPAN, are also utilizing the PeriPan service. So we're serving a lot more than this number of clinicians, but this is the metric that we all agreed to track over time. Okay, next slide. Thank you. So this is the data that we review pretty almost monthly. We continue to show some increase in first-time callers percentage and some increase, not as much as we would like in the last couple of months, in return callers. When we look, we have had a dip. We were really excited in October about our increase in call volume, and we have seen some decrease then in November and December. So we are talking with teams. I mean, this may just be a function of less people going to the doctors during the holidays and that kind of a thing. So we're hopeful that this bounces back and in the coming year. So we will continue to watch this very closely. We have talked with all of our teams about engagement and meeting the obstetrician and people in their practice where they are so that they can access our program as easily as possible. We have our texting service where they can text in as well. So really looking at how to ease that access and increase the utilization of PeriPan, so we make it as easy as possible for our very busy clinicians, because that's the boundary we continue to hear, is how very busy they are, how this is a service they want and they want to use, and they are we want to make it as easy as possible for them to do that. Let's see on here. We continue to see, we've had over 2,000 total number of consults. We have majority are physicians who continue to call. That's a little over 62%. We have nurse practitioners who call very frequently as well. And I think if you look at the next slide, we will see a breakdown of the physician type. And so 42% are obstetrician physicians who are calling. Next in the physician type are 18%, which are those pediatricians. So we have that. And then this resident category, we continue to await the clarification or categorization of our residents. Right now, we just have them in there as residents, but we want to know what type of resident they are. So that is in the current bill, or that is being built into trait, so that we can see what type of resident, and then those types of residents will go under the specific categories with a different color, so that we can see how many trainees are calling. We love that. A quarter almost of our calls are coming from trainees, because we're teaching this behavior to call this service and utilize PeriPan and CPAN for generations of practitioners to come. As they leave training and go out into the community in Texas, they know that they'll have this resource. So I think that's great. And we want to know what types of trainees those are. We imagine they're pediatric, family medicine, and obstetrician, and maybe some psychiatry as well. But we'd like to see the percentages and help us promote that use and educate about the use of these lines to our training programs as well. I think it is interesting here to see that about as many psychiatrists are calling as our family practice colleagues as well. So those psychiatrists who are out there treating pregnant and postpartum women and not quite certain of the next step in care, or what the standard of care would be for if a woman is breastfeeding, or if she's pregnant, or at risk of an illness postpartum, that we do have psychiatrist colleagues who are finding this service very useful as well. Next slide. This is our consultations by type. So we like to see about at least 30% of our consults going to our psychiatry team members. As a reminder to all, or those of you who are listening to the consortium meeting and aren't quite familiar with our PeriPan team structure, that we have behavioral health clinicians and we have a psychiatrist on our team. And we want to get the call to the most efficient, effective place as soon as possible. And we expect, when we look at other states, that about 2/3 of the calls go to our resource, referral, psychoeducation type calls that can be handled by our behavioral health clinicians. And about 1/3 of the calls will need to go to the psychiatrist. So anything that's that 1/3 or above, we feel really comfortable with. We had a little bit of a drop in December, that more people were handling those phone calls calls at the resource and referral stage, instead of at the clinician, the psychiatrist to calling clinician stage. And so we'll take a little bit of a look at that, but it's probably with the numbers that we had in December, maybe the difference of one call. And so we're not too worried about that. Next slide. This is an exciting slide because when we think about the data that does exist in our access projects from data from other states, we know that the initial call for resource and referrals is helpful to the clinician, but doesn't necessarily change their future behavior. The discussion with the psychiatrist to the clinician who's calling does look like it increases the capacity directly of that frontline clinician, and the direct patient consult does that even more. So we want to get as many calls as possible to that psychiatrist, and then we want as many of those calls converted to, when appropriate, that direct patient consultation. So we do see an overall increase in the direct consultations, where we're hopeful to stay up in this range and even higher over time. So even though our call volume dipped in November and December, our direct consultations increased. This could have been somewhat of a carryover from the increased call volume in October and just having some difficulty getting those scheduled, or some delay in getting those scheduled. But we were excited to see a bump in direct consults for both November and December. Next slide. So these are just a reminder of the webinars we have every third Tuesday of the month. These are free CMEs. We're available to our physician colleagues, our behavioral health clinician colleagues, our nurse practitioner and physician assistant colleagues, really anyone who is interested. We want to increase the knowledge base for those general pregnant and postpartum mental health questions that we see arise over and over again. So this has started. Our first one was last week, physiologic changes in pregnancy and postpartum, really helping people understand what happens in the body and how that changes metabolism of medicine and expectations around what might happen if a woman is on medicine or is prescribed a medication. And then you see the rest of the curriculum here for February through November. So we hope that you invite your teams, your departments, your training programs to participate in this really exciting curriculum that we've built, that we've worked with reproductive mental health experts across the state in developing this curriculum, and it will be delivered in from multiple experts across different departments of psychiatry in the state of Texas. Next slide. And then we wanted to talk a little bit about a new thing that we're doing. In the past, we have had our ECHO series, or Extensions for Community Health Outcome series, in a burst type format in both the spring and the fall, where we'll do 6 to 7 really close together every couple of weeks in the fall, in this series in the fall and a series in the spring. We have worked through an opportunity that we had with HHSC. We have been able to work with the Be Well program from UT San Antonio on a new ECHO series that will happen monthly. We're going to launch in March. We've been working really hard to get this organized, but we'll launch in March, and it'll be monthly instead of that burst format. And the ECHO series will tie in with the most recent webinar. And that way, that webinar format will be focused on delivering information, delivering education, but not, may have some time for question and answer, but not a robust clinical discussion. And then a couple of weeks later, we'll be able to have this ECHO patient-focused discussion where the clinician is able to present a case and have a deeper dive into the clinical application of that knowledge that they've gotten. So we've been really excited to partner with them. There will be a focused substance use component in many of the ECHO series, mostly because overdose is one of the leading causes of death in the first year postpartum, to really focus on increasing that capacity and knowledge base of our reproductive psychiatrist and of our colleagues across the state taking care of women in the pregnant postpartum period. Next slide. I think that may be it. It is. I'd be happy to take any questions.
All right, very good. Any questions for Dr. Wakefield? All right, Sarah, I don't see any. So again, thank you for all that great work.
My pleasure. We have a great team.
Yep, very good. With that, Laurel, let me go to you for the update from the Kosh.
Okie dokie. So I'm going to mirror some of the things that Dr. Wakefield says. Let's go ahead and go to the next slide. So this is our call volume for CPAN. We continue to see that seasonal variability with the November, December being lower, and we imagine there'll be an uptick come January. The other thing to remember is that just how the dates fell this year, that Christmas and New Year's were in the middle of a week. And so I think people just took even more days off than they normally would just because of how it fell. But nonetheless, we have, a sort of really robust number of callers, and we continue to see that growth over time. Next slide. This is sort of, again, just looking at it to that point of growth over time. The top blue line is the line that's for this current sort of academic fiscal year. And as you can see, there's been continued steady growth month to month when it comes to overall call volume into our CPAN consultation line. Next slide. Similar to Dr. Wakefield, we are tracking the sort of relative amount of involvement with our behavioral health clinicians and our child psychiatrists. And as she said earlier, we are working to have that sort of 30% or above of the calls involving our child psychiatrist. Every call typically involves the behavioral health clinicians because resources and referrals and psychoeducation are very important. But then additionally, there is that need to speak directly to the physician and have a physician-to-physician conversation. So we're pleased to see those numbers remaining steady in the mid-30s range. Next slide. And this is, again, similar to the perinatal. We have been tracking the number of direct consultations that we've been doing since we launched the pilot with the ARPA funding. And so we're very pleased to see that we have had another sort of steady rise in the total number of direct consultations that we provide for CPAN services. And we continue to see some good growth there month to month. Next slide. For those of you who are working on the sort of processes, we do have for Trait, our data management system, the ability to now start recording in Trait the direct consultations that we're doing. This will allow us to have even greater specificity around not just the direct consultation itself, but the reason for the consultation, whether or not the consultation was agreed to do by the primary care physician, whether or not the patient agreed to it or not. So we'll be able to kind of track things over time, including what the diagnoses were and what recommendations were provided. So we're very excited that that feature went live in October, and the phase 2 with the ability to have some insights within the dashboard will be happening very soon in February. As Dr. Wakefield, I think, also said, we are adding some additional specificity to the roles so that once again, we'll be able to break that number down. Like she said, example was the residents. We've also made some upgrades related to the different types of midwives that there are. And so we're very excited for that. We also have working towards the PCP portal, which was something within our ARPA funding that will allow for primary care clinicians to have their consultation begin with a portal so they don't have to call or text. So when they're working after hours, they could potentially put their consultation in. And then the next business day, the CPAN PeriPan team could respond to that consultation and start helping that primary care clinician. And then again, just improvements for the direct patient consultation, and various other things to sort of help staff efficiency are working and is slated to be done in this quarter. Next slide. Direct Project Echo Spring 2025. This says something that's not that, so it's okay. I just realized that it doesn't say what it wants to say. So we can move on to the next slide. So T-Chat, again, this is a slide that hopefully everybody's very familiar with at this point. We thank the evaluation team for providing this for us to you. We are continuing to see that sort of increase in referrals over time with that seasonal variation baked in as it is for child mental health services normally. Next slide. So the referrals are, of course, the patient's been referred by the school. This is enrollment where we've been able to reach the family, the legal guardian, and get parental legal guardian consent. So you can see the number of young people that their families have provided us consent. And once again, you're seeing year-over-year growth here. Next slide. This is again looking over time at the number of treated young people that have had at least one session in any given month. You can see that red line across is growing over time, as well as the number of actual sessions that the young person and their family are getting each month. So a nice steady growth with that as well. And this is, again, the slide sort of just, again, reminding us all that the vast majority of the care that's provided within the TChat services is providing a psychotherapy and or case management. That is the more common evidence-based treatments for children are a psychotherapy. So you have psychologists, LPCs, LCSWs, providing the sort of the majority of the work to help children and their family with a much smaller percent of times where a psychiatrist is involved. Next slide. We are working on doing some further assessment automation to look at outcomes, not just with the sort of functioning, which we've been doing now for over a year with the Columbia Improvement Scale. We are going to be automating several of the screeners that you guys approved several months back, such as the PHQ-9A, the SCARED, the CRAFT, Columbia, and others. This will be automated based on the child's age, as well as the type of screener tool will depend. Some of the screener tools are meant to be one and done. Others are meant to follow along if the first screener is above a cutoff score. So this will help the staff on our TChat teams make sure that the patients are getting the right measures to them when needed, and also help the families with automated reminders to complete the scales prior to the appointment, so that the clinician can actually have a conversation with the family about the importance of sort of how they're doing in care and move care forward. We do on occasion go on site to various HRIs if they're having any sort of just additional challenges. So Jen Cole has been very, very wonderful in that regards, going into different places across the state, helping immediate. We are working to develop some work groups to work on the sort of processes for intermediate services that were approved through the ARPA funding and the latest processes for our teams, as well as working with TA and ECS as always. We're also working on sort of developing a roadmap for conferences across the state as it relates specifically to TChat, so that we can be coordinated and really make sure that the conferences we go to sort of help get the word out to the right audience about the TChat services. Next slide. And again, we are working on some automations for the assessments, as I said. Single sign-on, as organizations in various HRIs have single sign-on, that the trait system will work to integrate with that, as well as doing EHR integration. That piece will definitely involve your team's own internal sort of review with your IT and other teams. So it's a multi-step process that involves a lot of close collaboration with an HRI. It'll potentially look different depending on the HRI and the needs that they have. I think that might be it. So any questions?
Very good. Any questions for anyone? Go ahead.
Hey, Dr. Williams, I had a question on the CPAN. You know, you said that information and referral was the larger percentage than the direct consult with the psychiatrist. Like, I think it was 70-30 or something was the last chart. Do we know what specific things those, like in terms of information and referral, what are they seeking? Like, what are the services that the PCPs are asking for assistance in finding? Do we have any idea like what the top 3 things are by chance?
I wouldn't want to completely say this off the top of my head, but with some caveats, I would say it's most likely a psychotherapy that they're looking to sort of help find a location based on the patient's age, insurance, particular concern, and then also just the resources of maybe how to address whatever the chief complaint or disorder is. We've been steadily working on our database of resources, so not referrals, but resources. So say you have an 8-year-old who's had a trauma, you know, we have within our database sort of information that you could give that's age appropriate to an 8-year-old, to a parent in English and Spanish. So we've been steadily working through our disorders and having sort of a resource database. The resource database over time will be able to answer those kinds of questions with even more specificity. So I think that we'll be able to say more about that in the coming time.
Thank you.
All right. Any other questions? Seeing none, thanks again, Laurel, for the great work that you guys are doing with both Kosh and CPAN and TChat. So the next item is a legislative update on the budget, and I'm just going to talk through this and give you some background. But before I do that, is there anyone else that has joined us since we called roll call? I just want to make sure that our attendance accurately reflects where we are. All right, I don't see any. So let me talk a little bit about the budget and where we are. Obviously, the session has just begun. We are a couple of weeks into the session right now, and with that, there's a lot of knowns and there's a lot of mostly unknowns related to a variety of things. And I'm going to talk about the budget. And so a little bit about the background of our budget. We have had two components. We've had GR funding and we've had ARPA. And the ARPA, as we've talked about before, at some point will come to an end. And things that we've been funding with ARPA will need to be translated into GR funds. So we've had I think, a privileged position over the last several sessions where we've been able to work with the legislature before the session and for them to put basically what we asked into the base budget. It's going to be a little bit different this session. And I think appropriately so that, with the ARPA dollars, there's a need to have discussion with the legislature of which of those projects will continue, or be modified. What's the right size of those initiatives? And so instead of putting everything that we've asked for into the base budget, they put in the GR of basically where we were before. And the things that are related to ARPA will need to work during the session to explain why they're important and how they are translated into the funding that we will see in the final budget. And so that makes people a little bit more nervous than in the last session, but I still think that we're in a very good position. And with the conversations that will take place, the programs will be funded in the ways that they need to be funded. So again, that'll be an iterative process of working with the legislature. And so the base budget came out on Wednesday of last week. We're still working with the legislature to figure out kind of the procedure in which they would like us to talk to them related to the gaps that we see currently in the budget. But again, just to kind of bring everyone up to speed, kind of where we saw the total amount of funding that we would need for the consortium to continue to fund what we thought were appropriate after we'd worked with each of your institutions was right around $399 million. What's in the base right now is $280 million. And so we have a little over $100 million gap right now that we'll be working on. And so when I look at the budget, the traditional CPAN, the Kosh, CPWE, the CAP fellowships, the external evaluation, the things that we had been doing over multiple sessions, those are basically fully funded in the budget. TChat, we used ARPA dollars to help us expand quicker into additional schools. They put in $160 million. Our request was $188 million. And so there's about a $28 million gap there that we're going to be working on during this session. On research, they put in 29.6. Our request was 33. And so there's a little over $3 million gap there right now. For administration, there were additional things that we added with ARPA dollars that are not there right now. But again, I believe there's support to get them during the process. And so some of the contracts that we have, some of the additional individuals that we would put in because of the increased breadth of the consortium, we're not there yet. And again, will be part of the process. So just kind of remind people of some of the things that were funded by ARPA. PeriPan, YAM, Collaborative Managed Care, other workforce initiatives, all really important projects, but they're all funded by ARPA. And there's a desire for the legislature to have that conversation. And so it's just not a smaller group of individuals making that decision, but a broader conversation. In the end, I think those programs should be in good standing, but there will be discussion on all of those initiatives. And so again, we have, we're still getting clarification on there are some ARPA dollars that have not been used thus far, about $19 million. We'll think that there'll be clarification in the supplemental bill that those will continue. So that's part of the answer of that gap. But again, there is about $100 million that we'll be working on explaining to the legislature why they're important and making sure that all their questions are answered before they put those dollars into the final budget. As we get more information, we will share that. We don't know yet when we will be testifying or how we'll be testifying, because again, we're not a state agency, but our ask is a lot of money and higher than a lot of state agencies. You know, it's at $400 million now for the biennium, and that's a lot of money. And so I think it's reasonable that the legislature would want to have that kind of conversation with us about the effectiveness of the programs, how they've been worked, our oversight, et cetera, before they put in the additional dollars. Now, I think one of the good things about this session is that there are dollars. There are dollars that are available to the legislature, but I would also say that there's several high ticket items that I see when I read through the press that will take a big chunk of those. And so they will need to discuss our needs for those additional funds along with all the other needs from the state of Texas. So that's what I know right now. And as I get more information, I will share that with you. But are there any questions or any comments that individuals have? Andy, Dr. Keller?
Yeah. Hey, thanks, David. First of all, I think you all should feel really proud of this. I mean, it's amazing. I mean, I think that, like David said, I mean, this is a tremendous vote of confidence to continue what's happening. And then I think it's very reasonable to have the discussions about the additional things folks are doing and to look at those. And I think also, David, you all did an amazing job. And I think the folks at the system level did an amazing job explaining a very complicated situation. Because, I mean, with the ARPA funds and everything going on there and to switch to that, I mean, it was just really well done. So I hope folks, you know, just first of all, feel really positive. I think that just a couple things, just maybe the one thing I would just emphasize is being really clear and focused on spending down the ARPA funds that end up rolling in, because I think, you know, that it's hard to do that, but we're going to have to do that. And I think that, you know, being thoughtful about where we do that, I think all of us have lessons learned about that. They're not the easiest dollars to spend, but, you know, the reality is if you know, I think that's one thing that we just need to be really confident about and also be really focused on. Some folks did that better than others. And I think all of us learning from each other about how to move that forward would be great. I think there's also some other cool things in the budget that'll help us. I think the expansion of funding into the youth crisis outreach teams, which is going to increase somewhere between 40 and almost $60 million, depending on, you know, where it ends up in the two budgets, is going to be a huge help and support to the consortium for youth that have higher level needs. I think the DFRIT research piece is an amazing, the Dementia Prevention Research Institute is an amazing complement to the research that we're all doing. So I think, you know, when you look at the broader budget, there's a real, a lot of recognition of the importance of what you all are doing. And I think things are well positioned. But I do think we do need to be on our side super tight and super focused on spending these ARPA dollars and showing that that we can do that and that the needs are there. Because if they're not spent, then people wonder why. Because not everybody appreciates how hard they are to spend. I mean, you know, we know how hard they are to spend, but left dollars that are left are, you know, raise questions, and we just need to be able to really be focused on that.
Thanks,
So
Andy.
that's why we just add that, David.
No, I think that's a really good point. Again, it was a special privilege that we were handed to be able to get the ARPA dollars to jumpstart these initiatives, to move them up faster, you know, on our agenda, to expand TChat quicker. But we need to make sure we use those dollars and use them effectively and serve the individuals that we asked the legislature to have the privilege to serve. And so please use those dollars. again, as we get more information, we will provide that to you. I think this is the normal process and is appropriate that we will discuss with the legislature in a very transparent way what our asks are and why these various programs are important and why they deserve general revenue funding moving forward as part of the comprehensive approach to improving children's mental health services in the state of Texas. Dr. Amador?
Thank you. I'm wondering if at a future meeting, we might put an item of discussion of how if the school voucher program does come into law, how this might affect our budget for the consortium.
Okay. Happy to look into that. It's going to be a little bit complicated, and it'll probably take a little while before that gets put into place, but happy to spend some time thinking through that and what its implications are for the consortium. Any other comments?
David?
Oh, I'm sorry.
Let me go to Olga and then to Andy.
On the 19 million remaining ARPA funds, are those currently unobligated 19 million, or is it expected unexpended?
Those are obligated. Those are obligated.
Yeah, they are dollars that are already at institutions' budgets and have been designated to provide a variety of services.
Okay.
Yeah.
Okay. Thank you.
Andy?
Thanks. I was just going to say that on Dr. Amador's question, I don't think it's going to affect us because I think that we're here to serve students regardless of what their setting is. So I think however the education system is organized, I mean, we have protocols set up to serve students in basically any educational setting, including homeschool. So I don't personally, it may be that we have to think through some focuses of how we apply, but I just personally, I think we're sort of outside that discussion. And I think it's really good for us to be outside that discussion because, fortunately, we don't have to organize the educational system here. So, or you have to organize your educational system, but not the K-12 system.
Yeah, no, we're here to serve and we will provide these mental health services. So we have prioritized the public schools, but we've also said that other schools can ask for these services. Again, I think for our ask, it doesn't change our ask for this legislative session at all. Okay. Other comments? So again, we'll have to see how this plays out. There will be a hearing for the Higher Education Coordinating Board next week. We've been told that we will not be part of that hearing for Senate Finance next week. But I do anticipate coming up in the near future that we will be asked to come and talk about the work of the consortium and what, with the $280 million, what does that buy, the demonstrated need for additional funds, and what each of the increments provides to the state of Texas. And in the end, we will figure out how whatever dollars that they allot to us in the categories that they have given to us, how do we, we'll do this in executive committee, talk about how those dollars will be distributed across the consortium. Okay. Any other questions? All right, hearing none, let's go to an update from Texas A&M regarding their hospital capacity report. I think Dr. Librazan and Dr. Ori are here, and I will turn it over to them. Dr. Librazan, are you there?
Yes, I'm here. I'm sorry I was on mute.
All right, very good.
So first of all, it's good to see all the colleagues again, and haven't been for those meetings for a while. So, congratulations, Dr. Leakey and the rest of the team for great progress with further expanding the services that TCMHCC provides. I mean, it's very impressive, and we are big fans. So, in a way, and I will start just a moment and then come back again in the end. And in the middle, Dr. Orr will be presenting a little bit more data. But the question here is probably less requires explanation. Why we got this mandate to study inpatient beds. it's pretty clear to everybody that there are wonderful task force or whatever we call that organization, consortium that looks at a lot of aspects of children mental health outpatient care. And I'm talking about, of course, you all and us within our departments and so on. However, it's not entirely clear that inpatient care received sufficient attention, and I think that was the main push that the Texas Children's Hospital Association and the legislator in their effort to figure out, do we have enough resources for the inpatient care for the children in Texas or not? And I think that was the main push to figure out what are the gaps, what are the areas that are needed, and how to, in a way, we think at least about that as a continuum of care, how to ensure a continuum of care between the wonderful outpatient services that are developed by all of you and the inpatient needs for the children in Texas. And basically, you all know how critical it'll be. What maybe not all of you know, because outside of the main areas, that many areas in Texas do not have beds, and we'll talk about that more. But really the beds availability is geographically, I would say, varies. And the critical component here, I think, that we will try to complete during our second year is that try to understand how best to approach that, because as you can imagine, it would be wonderful if we could put bed closer to every geographic location, but everybody understand that there should be some kind of a reasonable concentration of beds in order to provide services that are at the level that we would like them to be provided. So how to deal with this geography, Texas being a big state and so on, and the needs which are distributed unequally, of course, and also resources, and not always needs and resources overlap. That's type of challenges that we have been dealing with, trying to understand and share that with the legislator. We have done, so they came to us obviously because together with psychiatry, we also have a strong School of Public Health group that helps us with that. And Dr. Ori's, my co-defendant or co-conspirator in this process, is will be talking to you about it. And she's a distinguished professor from the School of Public Health. And of course, even with all of that, we need a very strong coordination, and we tried to do that, coordinating with Health and Human Services and the state state task forces. There's a lot of state agencies as task forces that we need to kind of talk to try to understand the situation and get feedback and try to incorporate in our meetings. So the meeting really in our report. So right now what we're talking about is the first year report, because we spent first year and trying to get as much information as possible. And we provided this preliminary report. We submitted it to legislator and now sharing that with you in a way. And we will be looking forward to continue working during the second year including creating, we are expecting to start to have at least toward the end of the spring roundtable discussion about that, and would love to have a representative, maybe Dr. Lakey or other from TCMHCC to come and join our roundtable discussion, which will kind of further clarify both the needs and recommendation. So at this point, I would like to ask Dr. Ori to continue this presentation. I'll jump in at the end again and we'll answer question if needed. Marcia?
Thank you so much. Can you move the slide to the next one? I'm also really pleased to have the opportunity to present. Our final report is available to anyone who hasn't seen it. We're glad to share links, and perhaps if we share it with Monet or someone, then everyone who wants the link can see it. But if you think about our goals, we really wanted to understand where we are now and where we need to get. And so the three biggest goals we had were, one, to estimate what is the current use, and then the need for psychiatric inpatient care for children and adolescents. But we just didn't want to stop with demographics. We wanted to understand the challenges, the opportunities of providing such services. And then, as Dr. Lieberson has already said, we are coordinating with a variety of statewide agencies, both governmental agencies as well as associations like the Children's Hospital Association of Texas. We have three different kinds of data. We did a literature review. We took advantage of what the statewide behavioral health coordinating council had produced in their work toward the strategic plan, but we also looked at best practices. We have secondary data from public use files, and that's what we'll talk about in three of our slides. And then we really wanted to hear a voice from the community. So we did key informant interviews, and I know some of y'all were people that we got feedback from. So next slide, please. We're going to have three different slides that sort of give you a feel for the data. We know from the literature that the estimate of beds, that 30 beds per 100,000 total population is the minimum standard. Some people would say that's just the minimum. We need 60. But what do we see in Texas? We see across the whole state just 22 beds per 100,000 total population. So we're on the low end. But just what Dr. Lieberson said is really important. If you look at this map, you see there are just a few counties that are at the optimum level. Of the 254 counties in Texas, 227 of those counties have no psychiatric beds. That's about 20% of the Texas population. But what's also important is that 22 beds per 100,000 is probably an overestimate, because with the current data, we were unable to distinguish what was a bed that was an adult bed, a geriatric bed, or a child or adolescent bed. So overall, that's what you see, the 22 beds per 100,000. Let's go to the next slide, please. We also looked at inpatient discharge, and this was specifically for children and adolescents. And we were really shocked to learn that almost half of all of inpatient discharges in Texas involved a primary psychiatric diagnosis. We had no idea that we would find this. But then when we looked at what kinds of diagnoses there were, certainly depressive diagnosis, mood disorders, that's where most of the diagnoses were for this pediatric population. So again, you can see sort of a heat map of hospitalization discharges across the state. And the next slide, please. So we also wanted to look at emergency department visits. And these were specifically, and we talk about children and adolescents, this is the 5 to 17-year-old group. you see very severe reasons why people are going to the ED. Suicidal ideation, attempts, self-harm. That was the most prevalent primary diagnosis for children at ERs. But also there were the anxiety, the fear-related disorders, depressive disorders. This just gives you a sense that, the sort of magnitude of hospital beds, but again, we think it's an overestimate, something about inpatient utilization, and again, about ED visits. Let's go to the next slide. What we'd like to do is take all of this data, and I want Israel, who really lives and breathes mental health issues, to tell you about our takeaways.
Well, thank you. The point here is we kind of, as people understand, working with legislators, we need to have a thoughtful way of presenting the data, and it's a little bit too soft for my taste. Many of you know me. I am a kind of a straight talker, and so the first point here is basically saying we are not producing as a state a good data. The legislator, basically nobody knows. I mean, in my mind, it's a problem that we cannot distinguish psychiatric beds, children from adults. And we actually we are working on each hospital, calling them separately, each hospital trying to figure that one out. And that's not clear. Still we're having a hard time to get the data. So Sarah, in a second, I'll stop and let you ask. So we feel strongly that first and most important thing is that the state to start expecting from all of the hospitals at least to report how many pediatric psychiatry bed they have and what was the occupancy and who was in those beds. And that's the critical points, because without us getting or without whoever is planning getting this data updated and current, it's very difficult to make a final decision. Go ahead, Sarah, please.
No, thank you, Israel. I really appreciate this data, and I can also appreciate how difficult it is to get this data. I really want us to. I wanted to just kind of double down or talk more about how we define a pediatric bed. Because here in the Panhandle region, there are hospitals, and I think this happens across the state as well. There are hospitals that admit kids into a bed, but they don't have pediatric clinicians to see them. And I think we need, and again, that is a service that because if we don't have any bed to send the kiddo to, I think it can be better than nothing. In some circumstances. But if we're going to plan and make future plans about what our state needs, we really have to delineate the difference between a bed that we want a kid in that has pediatrically trained clinicians and a bed that is able to have a child sleep there, but they're not seeing people who are trained to see them. And I think those are very different things with very different outcomes. But we haven't had that data before. So it sounds like you guys are looking at that. But I wanted to make sure that is something that we're able to look at and define here, because I do think it changes the outcomes for kiddos.
No doubts. And Dr. Wakefield is 100%. I couldn't ask for a better interjection here, because, as you will see, this is some of the question, some of the other findings that we report. So when I talk about pediatric, to me, the bed itself, it's the size of the bed. No, the only reason what makes pediatric psychiatric bed is the stuffing, right? Not in the physical, but the most important, most difficult, and most difficult to get thing is appropriate stuffing. Trained doctors, and so on. So when we talk about that, we're trying to get a number. What is the hospital officially what kind of resources they have and how many beds they have, that based on their resources. If their resources is for one bed, they cannot say that they have 5 beds. To me, that's not a correct reporting at all. So we speak specifically about it, and I must say that your situation is not unique there in the handle. I mean, this is true for all around Texas. Everywhere as you get outside of the large metropolitan areas, it's also obvious that, of course, it's important that they'll continue admitting kids, and when they need it, you cannot just send them. And this is another geographic issue. It's impossible to send them, and we do. In Brazos Valley, we send kids 80, 90 miles from their home, and 80, 90 miles completely does not allow parents to be with the kids. And as we get in the lower points here, these are the major takeaways, because you will see both the workforce and the need to provide. Today, if you look on the literature, everybody will tell you that the state of the art is based on family interventions and continuity of care. So creating a bed, which is great, but 90 miles away, and the parents cannot be there because they don't have enough money, because they are working and so on, prevents them from being available as a high quality care inpatient treatment, right? So all of those components are critical. And some of the thing is developing, basically we're discussing all the following point. Thank you, Dr. Wakefield, for bringing it, because developing infrastructure that support the adoption of best practices. And best practices, this is exactly integration and coordination of across the continuum of care. And we gently mentioned here strengthening the workforce capacity, because this is exactly what Dr. Wakefield was talking about. The hospitals might want to have the beds, they might have an infrastructure to create the bed, but if they cannot have well-trained or sufficiently trained staff, those beds cannot be considered as pediatric psychiatry beds. It has to be geographically distributed so people can get to it. That's what I was mentioning about 90 miles, at least in Brazos Valley. That's the situation where people drive like that. There's places probably that are much more than that even. And then last point, which is also critical here, is that, and I'm kind of trying to say, we need to talk about, at some point, we need to talk about, as a society, is about reimbursement, right? We all understand the political issues involved, etc. But the hospitals cannot provide high quality intensive care if they are losing money. And that's what we hear from hospital administrators, that they cannot increase number, but they don't want to increase the number of beds because they're losing money. And of course, we cannot expect the hospitals to lose the money without any control. So we need to have a discussion level of decision makers and legislators that there should be a match between the reimbursement and the hospital expenses. So those beds have to be created or maintained in appropriate way. So I believe that's the last slide. Marsha, do you want to have
one more slide, I think? Yeah. And this is our reflection back to the group, if y'all have any questions or comments for us.
This is Sue Shell with Children's Health in Dallas. Dr. Liberzon, I totally agree with all of your comments about funding, and hospitals can't open up more beds and lose more money. I just always have to put a plug in that when we talk about funding from the state, from whoever, grants, we have to also include outpatient and intermediate levels of care. We are working very hard to grow our outpatient programs at Children's in Dallas, similar to, the TChat program, catching these kids and the CPAN, catching these kids early on in the process, getting those interventions to them in real time so that issues don't continue to the point that they need an inpatient solution. So to me, that is our biggest priority, is to get higher rates for outpatient care.
I just want to say one thing on that. I think for a long time, there is a perception within the community, us who take care of our patients, is that it's somehow becomes a zero-sum game. I don't believe so, and I don't think we should see it like that. I think both outpatient and inpatient services have to grow and match each other. We should not give a sense to legislators that one or another, because by doing that, we're hurting our children's care. Doesn't matter on which side. To me, it's providing less than optimal. So yes, I absolutely agree with you, and we are seeing that. That's why we talk about continuum of care. If you look on the previous slide, we talk about what are the other services. For example, if strength of workforce capacity, convenient inpatient care, but integrated and coordination of services across the continuum of care. If you see the point number 3, this is exactly going into your point. We absolutely aware and try to make that point as clear as possible. And Dr. Wakefield has something to say.
It is a question this time, sorry.
Sure.
Marsha, I'm wondering if you guys in your key informant interviews, if you're including families. Okay, great. I don't know if you have.
Unfortunately, we didn't. We included people who serve families, but we didn't have voices from parents or families themselves. That's probably a limitation. And when we go to the roundtable, we're going to, ask people what's the most important feedback we should get. And I gather, Sarah, you're saying make sure that you don't lose sight of the voice of the people you are helping. Is that your point?
Well, it is partially my point. I mean, that is very much my point, but I think more than that, there's really good data there. Again, being in such an underserved area of the state, we send kids all over the state for inpatient hospitalization, and their stories when they come back are very demonstrative of the difficulties within the system. And so we hear when it went well and when they had family involvement, even if the family was geographically, further away, how they helped facilitate that, how it helped the family feel more empowered and educated about that kid's transition home, how they did discharge planning and all of those things. And then I also hear families that say, no one called me until they called me to tell me to come pick up my kid. And I didn't know anything. And I never spoke with a physician. I never spoke with anybody. And I think until you know that that's happening, like as a legislator, as a person at the state level who is helping orchestrate and organize the future planning around this, until you know these wide disparities that are happening, but we're calling it all the same type of care, it's really hard to start setting standards and knowing where those standards are being in place. But the families know, and they will tell us, they will beg us, like, please don't send us back to this hospital. And we'll say that's the only hospital that has a bed right now. And so we'll have these conversations over and over within our hospital, our inpatient pediatric hospital or outpatient clinic settings. And I think those voices are not just valuable because they show, they have that voice at the table, which is really important, but there's really good data there that you're not going to get from the other side. They just don't have that data, or potentially they have it and are not willing to share it.
Thank you so much. This reminds me, when we do have our roundtable in the spring, we should try to get some family representation. But as you say, each family is separate, so it's hard just to get one person to reflect a family view. But thank you so much for those comments.
Let's go to Lee and then Trina and then Sarah and then Octavio here in the room.
Being minded of the time. Oh, yeah. Yeah.
Thank you, Dr.
Okay, that's what I wanted to give David an opportunity to manage that. Thank you, Dr. Lake. I appreciate that.
Israel, you're coming in and out just a little bit right now, but let me go to Lee and then to Trina.
Thanks, Dr. Lakey. I appreciate it. So I'm looking forward to reading this report, and I'm curious how or if you guys looked at the fairly substantial investments that the legislature's made over the last 3 legislative sessions in inpatient care in Texas. In particular, the investments that were made last legislative session, which I would say are fairly historic for our state. I'm curious if you looked at any of that and how that was considered in the report that you put together, given that we're kind of in the stage now where new hospitals are being constructed and new capacity is still a few years out from being online. So I'm just curious how y'all dealt with that.
I think that's really important. In fact, tomorrow we're going to talk to a representative from the governor's office, and thank you. I'm sure they're going to ask that question too. Unfortunately, the latest data that we had was 2022. So it seems like we're not going to capture investments that were 2023, 2024, and in the future. But we do know that the state hospital system is investing, widely, but that's just a part of the hospitalization. That's not general hospitals, private hospitals. But I think you're right. We need to think not at one point in time, but how things are evolving, and not just evolving poorly, but what the state's doing in a positive way. So I think you're right that investment is important, but just like what Israel said, it's not just the bed, it's got to be the bed with appropriate staffing.
Let's go to Trina.
Thank you. First, I'd just like to say, Dr. Liebezan, I appreciated your comment about this not being a zero-sum game, that there has to be, kind of appropriate attention to an investment across the system when you're building a continuum of care. Because I hear people talk about that balloon analogy, right? If you squeeze one end of the balloon, then it becomes bigger on the other side. And so, your comment is well noted and appreciated. I do have a question going back to the data that you talked about in terms of the bed capacity per 100,000. I'm curious to know what other state would you, and if you said this and I missed it, I apologize. What other state would you say is doing this well in terms of capacity when you look at a comparison of beds per population? That I would be interested to know that. And then I have one other just comment related to what you noted about, hospitals wanting to do this work, but can't give bed capacity because of the cost to do really good quality care. There's a price associated with that, which is helpful to know, because what I often hear about some of the most complex cases in terms of justification for discharge or not serving is that children are at baseline, or they're what is happening with them is behavioral. And I find that challenging to hear because, kids are being habilitated, right? And I think with these kids, when you talk about really hard kids, to me, that seems an impossibility to unmarry their behaviors from their psychiatric or their trauma or the other issues that do necessitate inpatient need. And so I just wanted to say that for the record, because we hear that too often, where reasons for discharge or not accepting a child into a hospital setting is that it is a behavior, when I struggle with that. And so if somebody can give me clinical justification for why that is so, I would hear that and be open to it. I just don't believe that to be the case, that you can unmarry the two based on my own clinical training experience.
Absolutely. Let me answer the first one, which is the easier one. When we asked your colleagues in state, where were the states doing best? And they ended up as best practices in the report, it was Ohio and New Jersey. And I think what makes them good is they have what we're talking about, a better integrated system across the whole continuum of care. So the next question, I think, is an Israel answer.
Right. And although, I mean, it's true that Ohio and New Jersey are coming up, but unfortunately, if you look on that, you will see the state that have more resources and state that are more willing to support traditionally mental health, traditionally, because we are big difference here. With the TCMHCC is an enormous change in my mind in the landscape of mental health services. But yeah, I absolutely agree with you. This is discharge or behavior is not different than any other. Everything is behavior. I mean, come on. I mean, this is a ridiculous answer. What they want to tell you is that they believe that the child is in what they would call baseline state, or that's how the child will continue behaving. We cannot make further steps. We cannot improve anymore. That's what basically they're saying when they're saying, oh, it's just behavior. What does that mean, just behavior? So to me, it's a very poor description of and poor understanding of what we're dealing with. And basically what they're saying is that they don't believe that the child can be further improved in inpatient setting. And at that point, I would say, well, what do you want to do? I mean, yeah, maybe you personally don't believe that child can be improved, but if the child cannot be sustained in outpatient condition, if the danger is too much, behavioral disruption is too much, then maybe we should transfer it to the place where they can be treated or can be improved. It's not a question of behavior. Behavior, everything is behavior. That's at least my point. I don't believe that. I think the people want to say, okay, the child is at the baseline. Well, sometimes what they consider the baseline is unacceptable. That's why they get in. So I think, I'm not sure I'm addressing your point, but I'm trying to.
No, that was helpful. I appreciate it. Thank you.
Let me go to Sarah Martin, then Octavio, Luann, then Steve Pliska. So Sarah?
Everybody has a lot to say. Yes. I just wanted to say in El Paso, we have a very specific problem where we have a lot of child and adolescent beds in private hospitals, but the children who have the highest needs aren't accepted into those. They can say no. They don't even tell us the reason if they're not accepted. They just don't accept them. And so those kids, of course, end up in the ER. So we only have a 2-hour-a-day service at the children's hospital, and we have managing those kids in the ERs, and it's a bad situation.
Yeah, having a beds but not available for children is not having a beds in my mind. So that's how I translate that. And if my bet is some of their problem is exactly the same thing that we're describing. They don't have enough staffing, or staffing is not important, or for not appropriate, or they have too many difficult children, or their beds are occupied by somebody else. I mean, to me, that's the only explanation. So basically, we're going back to the same issue. But it's important when your comment, Sarah, about they may be formally claim that they have beds, or they have a psychiatric hospital, or what a private hospital with psychiatric beds, but in reality, they don't meet the criteria of the necessary staffing. Maybe that's the situation.
What we also found was a difference in insurance coverage. Those people who get hospitalized are most likely to have insurance, private insurance. Those people who end up in the ER are most likely to be on Medicaid. So it may also have to be something about the ability to afford care. What we do know, the average length of stay in our study was something like 8 days. That's a long time to go without insurance.
Yeah, but that's also not equally distributed. So we have not plotted that carefully, but my bet is like in everything else, the length of stay will be shorter, but some small group will be very long time because of the placement issue and so on.
Octavio?
Hey, Israel, really great that we're having this discussion. My question for you is, are you able to address, or are you pulling in the factors that impact children and families, given the diversity of Texas from a cultural perspective, as well as understanding that, folks are, Medicaid, they end up in the ER versus those that are funded and they're getting hospital beds, that there are the non-structural drivers of health and mental health that are impacting them. So I'm wondering how you're capturing that component as well.
I think, Octavio, your point is extremely important. The two ways that our data might try to address that is by geography, simple geography, saying, look on the counties where the demographic distributions and so versus the counties and that talks about diversity demographics, which include everything, including financial differences. I mean, what are the counties that with average income is much lower than others, and so on. The cultural differences also can be picked up on the same level, because we people do collect some demographic, but not always we have sufficient information. I think your point is very important. Demographic is often used for larger scale, kind of a proxy for your question. But Octavio, I hope you can join us in the round table. We will send you an invitation, because to me, this type of question, how to deal with it and how address it, is really critical. And I would love to have you talking to us about it in few months. If you're willing to do that, we would love to have you.
Yeah, thank you, Israel. Absolutely.
The only thing I would say, for the first year, we wanted to get a very broad stroke. In the second year, we're going to try to zero in on more characteristics of both community and characteristics of people who have inpatient utilization.
Luann?
Thanks. Well, first off, Marcia and Israel, thank you very much for this study. I know I've had presentations about it several times and I learned something new each time. So I appreciate that you did this. Many of us, I feel like I deal with this on a daily basis, issues around hospitalization and the need for a continuum of care for crisis services as well. And Andy did mention the wonderful investments that have been made in children's crisis services over the last several sessions. To Lee's point, also when we look at the future, during the last several legislative sessions, pediatric psychiatry beds were financed. I think UT Southwestern has some coming online in the next few years. And I'm just wondering if you all, when you looked at your capacity study, are also taking into account the timeline of when child and adolescent psychiatric inpatient beds funded through the state will be coming online as well, and where they're located geographically too. I think there's a 16 bed, if I'm not mistaken, at Uvalde, and I don't remember how many beds in Dallas. I think there's folks from UT Southwestern who could probably answer that today, but
92.
there you go. Thank you, Dr. Ibrahim. And so I think that also helps us look across the state at what we have now, what we have planned, and then what is needed as well to meet that 1 to 22 ratio, or 22 per 100,000 ratio that you all talked about earlier. So I really appreciate that you've done this study, and look forward to further conversations about needs. So thank you.
Thank you, Luann. That will be wonderful. And the same way, like Isham, I hear your voice. I don't see you in the picture here, but I really appreciate the input. Thank you so much. And we would love to hear. One of the things is that we probably can get better information from TCMHCC member than us trying to call the hospital administrators. That's another issue. But we really appreciate that and hope that we can continue this discussion because of the specific points that Dr. Wakefield and you and Octavio and everybody else brings up for us all to kind of to make a better, more rich and more precise picture. So we're really looking forward to your input as a critical holders of information here.
Let me go to Steve Plitzka and then Lee. I see your.
Yeah.
Okay. Lee?
Oh, just a very quick question. How do we participate in the roundtable discussions to come?
We have a planning group that is like, working on invitations. We're trying to keep it relatively small, like the 20 to 25. But if people feel that somehow they have something special to offer, let us know. So that's the goal. We don't want it to all of a sudden explode to be, 100 people. So the idea is to keep it relatively small. But Lee, we would welcome, as some others, a little bit more input. So thank you for letting us know.
Thanks very much. Appreciate it.
Very good. Any other questions? Sarah Wakefield?
Sorry, I will ask one more question. This was brought up by someone else, but I think just the idea of, Sue, you brought this up, the idea of the step down services and how one of the things that we did, our community did a mental health needs assessment with multiple partners across the community several years ago. And there was this recommendation for a certain number of beds. And I think we had a lot of discussion about people saying like, well, is that truly enough beds? And in my experience as a pediatric clinician, kids don't the majority of kids, it's not true that all kids, but the majority of kids don't need to be in the hospital for very long. They need to be stabilized in the hospital fairly quickly. But then the only way to get them out of the hospital quickly is to not send them to a follow-up appointment 2 or 4 or 8 or 10 weeks down the road. It's to step them down to a partial hospitalization or intensive outpatient program where you highly utilize family engagement interventions, and then they have much more success. And so I know that's probably not the focus of it's a big enough question about what you're doing and trying to answer around inpatient pediatric beds, but I don't want to lose sight that we will need more beds if we have less step down services.
I absolutely agree with that, Sarah. And I think that the way that we probably will try to address that, at least initially, because Marsha was emphasizing to me the importance of including so-called success cases, places where doing well and what makes them success, and them sharing that. And I think this is exactly what you're talking about, that we will, and that was my hope, was those areas that feel that they have better services and so on, they all will have continuum of care with step down services. And I think that's how, when we describe that, I think that will be one of the critical evidence for to the legislator and so on, what's needed or how to think about distribution of resources.
Sarah, we are proposing a PHP, adult and pediatric, for the new Dallas hospital.
I love that. We started with a PHP and IOP with kids here. We had limited resources and we couldn't do all of it at one time. Our inpatient is coming hopefully in 2026 is the plan, but we made the fundamental decision to start with the step down services because those were closer to home and then we could keep kids in those longer. And if we still had to send them out of the community for inpatient, then at least we had a step down for them to come back to. And I do think we've seen tremendous results because of doing that. Now we do feel like we need that next level of care so that we don't have to send kids out of our community for any step of the process, but it is that PHP and IOP, we have seen tremendous results and families just being so very grateful in the treatment outcomes after recurrent years of repetitive recurrent hospitalizations outside of our area.
Right. So I think we will review that in the best practices, right? When we of our final report, and also highlight the fact that those places and show that the place that have those services really do better vis-a-vis the services, inpatient services. So absolutely. And Hisham, if you will take the numbers from you just to add that part for the discussion. But this is really critical component that we are planning to highlight.
And Nisham, I know you have amazing, very, very skilled clinicians there, but if we can share any of our practices and what we've done so far in our partial here, be happy to share those because it's been a labor of love developing that service.
That'd be great. Yeah, we do have an existing pediatric PHP that we've done for many years with Children's Health, really.
We would love to, Dr. Wakefield, we also want it. Whatever you're sharing with Dr. Ibrahim, please share it with us so we can give it as an example of what kind of approaches are used in the state. As I said, we will be giving examples, and that will be an important potential add-on to our data.
Happy to. Thank you.
Thank you.
All right, very good. Well, thank you, Dr. Liberzon and Dr. Ore. Obviously, a robust discussion because it's a really important issue, and we look forward to hearing further about how this work moves forward, and looking forward to how we solve this problem here in Texas. So again, thank you for doing this very important work.
And thank you for inviting us.
Yeah, we really appreciate the opportunity and the input that we get.
Very good.
Bye-bye, guys.
So we have one more presentation, and we're going to make this very quick. If we could put up the slides. All right. So one of the goals of establishing the Mental Health Care Consortium was that it would be be used to help Texas move forward in securing other mental health funding in the future. Several of us have had this discussion before. If you look at money that comes from the NIH to the state of Texas, we rank about 7th in the nation compared to other states. If you put that on a per capita basis, we're about 30th in the nation related to money from the National Institute of Mental Health. So one of the goals was, as again, from the very beginning, is to use the work that we're doing to help us leverage additional federal funds in the future. And so what NAGLA has put together here, and thank you, NAGLA, for doing this, is a list of what we think are current federal projects that have leveraged the work of the Mental Health Care Consortium. And we're just going to go through it very quickly to make sure that you are aware of the list that we currently have. And if you have other examples of how the work of the consortium has been used to bring federal funds to the state of Texas, we would like you to send that to us. We're going to keep this list as up to date as possible, because again, I think that is one metric that's important as we look at the overall success of the consortium. And so we can go to the next slide. So we talked to the individuals that run both the Youth Depression and Suicide Research Network and the Trauma Network, and asked them about how those research projects have been leveraged to secure additional federal funds. And I'm not going to read these slides to you, but we have examples here of grants that have been funded and grants that have been submitted or resubmitted. I'll just let you look through that for a second, and then we'll go to the next slide. And again, this is from the Youth Depression and Suicide Research Network. Okay. So, okay, if we go to the next slide, a second page from them. Again, they've been very busy and have been leveraging this work to, again, pull down current or future federal funds. I'll just let you read through it real quick. Right. We go to the next slide. For the Trauma Research Network, they currently have applied to 3 grants. 2 of them are federal. And as a result of the established network, and the 2 grants have been awarded, bringing in an additional $4.4 million of NIH funding or HOG Foundation funding for a pilot grant. And they're in the process of submitting an NIH grant for further explore sex differences and trauma exposure and outcomes among kids that have had childhood trauma. Okay, we go to the next. Another couple of federal funds grants that we are a part of. One is a PCORI grant led by the National Perinatal Access Network, Lifeline for Moms. Again, you can see the dates and amounts. Again, the small amount initially, but then it builds as these practices participate to become a substantial amount of money. I'll let you read through that. And everyone should have these slides, have us access to these slides. Okay. Go to the next slide. We were approached by HHSC last year to help them secure the Texas Maternal Mental Health Substance Use Disorders Grant funded by HRSA. It was funded in the amount of $3.8 million. And it uses the Perinatal Access Network to again use that as part of the in partnership with Be Well Texas to improve substance use services for women in the perinatal period. I'll let you just look through that real quick. And then if we can go to the next slide. This one is currently being applied for. A grant from AHRQ. Texas A&M was the lead in partnership with UT Health Houston, UT Health San Antonio, the Texas Health Institute, and the consortium to improve rural and underserved behavioral health identification and treatment in Texas. And so we'll hear back hopefully in the not too distant future whether Texas will be one of the entities that are funded. If we go to the next slide. Okay, that's all the slides, and we can take that down. I just wanted to share that information with you. And if you have other examples of how the consortium has been leveraged to bring in federal dollars, please let us know. We want to make sure that we have, again, an up-to-date list because that was one of the goals as we initially established the consortium. Any questions? And again, the goal of this time was not to go through the details of each of those grants. Again, you can look through that information that has been provided. But again, just to show you that in multiple ways, in the research, partnering with state agencies, partnering with other health-related institutions, the investment from the legislature is being leveraged to help grow funding for federal funding here in the state of Texas and federal research in Texas. Okay.
David, this is Cheryl McCollum Smith. What types of federal funding, any federal funding, and what kind of link does it need to have to the consortium?
Yeah, so I guess I would say talk to us about it. Okay. If it's something that you were doing otherwise that really isn't related to the consortium, I don't want us to take credit for that. But if by establishing the 2 networks, they are getting preliminary data to bring in federal grants related to that. I think that is appropriate. When state agencies ask us to leverage the programs that we have developed, they can secure additional federal funds. I think all that is appropriate. And so we'd be happy to talk to you. Again, we don't want to take credit for work that you were doing otherwise, but again, the goal is to grow federal funding here in the state.
Right. So would it need to be child? Not necessarily.
I think well, it depends. Like with the perinatal work is not necessarily child, but it is related to the consortium work. But if it has a direct tie, that it wouldn't have occurred unless the consortium was here and the infrastructure the consortium has built, then I think that would be appropriate.
Okay. I'll talk to you. Yep.
Sounds good. Any other questions? Well, hearing none, it is exactly noon. And so I appreciate your time, and we'll give you a little bit of time back. And again, as the legislative session proceeds, we will give you updates about how things are going and what's occurring with the budget and the funding of these really critical programs. Hope you all have a great day. Thank you.
Thank you.